I am Valentin Fuster from New York, and I'm very pleased today to review the different presentations at the European Society of Cardiology Congress 2024 in this beautiful city of London. And I'm very pleased to have with me 4 masters on different aspects in the cardiovascular field who will be able to discuss with me the most interesting papers presented in the Congress. So just to give a view, we are going to discuss 9 papers, if we have time. One on cardiomyopathy, the vutrisiran story on amyloidosis, 2 on atrial fibrillation, OCEANIC-AF, asundexian versus apixaban, the inhibitor of factor 11. Very exciting, actually. The EPIC-Coronary artery disease, endoxaban in patients with atrial fibrillation and chronic coronary artery disease. So 2 papers for atrial fibrillation. Then we have 2 papers for myocardial infarction. The A-beta-YS, or AVIS, beta blockers interruption following myocardial infarction is good, is bad, we'll discuss. And then the FIRE study, complete versus culprit, revascularization in patients with myocardial infarction, in this case with a functional assessment of the non-culprit lesions. Then in valvular heart disease, Notion 3, PCI in TAVR, patients who have coronary artery disease and aortic stenosis. RESHAPE-HF, again, moderate cardiac dysfunction in patients with functional mitral regurgitation. That is the approach with TER versus normal medical therapy. And then the Patternhorn study, which is again moderate mitral regurgitation in patients with functional mitral regurgitation and moderate dysfunction of the left ventricle. In this case, is the use of TER versus surgical approach. And finally, a very controversial paper, semaglutide in patients with COVID-19. Okay, so a lot of news about this last paper, which will be worthwhile if we have time to discuss it. Well, let me now introduce my friends here, real experts in the field. Let me start in my left, Dr. James Janussi, who is the Adolf Hatter Professor of Medicine at the Harvard Medical School, a staff cardiologist, by the way, a very good cardiologist, at the Massachusetts General Hospital and Chief Scientific Officer at the Bain Institute for Clinical Research in Boston. Then we have Dr. Christine Albert, Professor and Chair of the Department of Cardiology, and the Lee and Harold Kapelovitz Distinguished Chair in Cardiology at Cedars-Sinai Medical Center in Los Angeles. But the best title is she was a fellow when I was at the Mass General. That's the best title, Christine. And then we have Anna Sonia Petronio, is Chief of the Catheterization Laboratory of the Cardiac and Thoracic Department of the University of Pisa in Italy, where she's working as interventional cardiologist. And finally, we have Dr. Gray Daly, who's from Oslo, consultant at the Department of Cardiac, Thoracic, and Vascular Surgery there. And she's the director in Europe of the International Society for Minimally Invasive Cardiothoracic Surgery. Well, with these introductions, let's now go into the details. And let's begin with the first paper, which is the paper from the HELIOS-B study, published in the New England Journal of Medicine. The primary results are a phase 3 study of vutrisiran in patients with TTR amyloidosis with cardiomyopathy. This paper was presented by Dr. Fontana from the University College in London. Well, what we can see, tafamidis, basically what it does, it prevents the deposition of amyloid fibrils by actually blocking the tetramers to become monomers and to be deposited. But here we have a new drug. Vutrisiran is actually given subcutaneously in an RNA therapeutic inhibitor. That is, we are really blocking the synthesis of amyloid. Very exciting from a theoretical point of view. So let's now go into the studies. A randomized double-blind outcomes study in ATTR amyloidosis patients with cardiomyopathy. The patients were receiving vutrisiran subcutaneously, Q3 months, 25 milligrams, and placebo also every 3 months. The number of patients, 655, and the patients underwent, of course, randomization, as I mentioned. They have a wild type, 10% was a variant of the ATTR. These patients, New York Heart Association classification, were mostly in class 2 to 3, and but in terms of 6-minute walking test, equal or more than 150 meters. I would call this moderate type of amyloidosis, of cardiac amyloidosis. Primary endpoints, composite outcomes of all-cause mortality and recurrent cardiovascular events. Follow-up, 33 to 36 months. Interesting secondary endpoints, the walking test, the 6-minute, the Kansas City cardiomyopathy score, all-cause mortality, and changing in the New York Heart Association functional class. Very well-designed study, and now let's go into something that is maybe a little bit complex, because there is a group called combination group. Tafamidis was used at the same time that vutrisiran in patients who were using tafamidis before. And actually there is the group that is the monotherapy group, which is only vutrisiran, but let me say that 20% was a crossover, so they needed tafamidis. So I'm just mentioning this, but it still is monotherapy. Well, these patients, the average age 76 years, there were 93% were male, and actually the number of patients who had the variant of TTR were about 10%. Okay, let's now move into the results, straighten. Primary endpoint, well, very significant in terms of the outcome of all-cause mortality and recurrent cardiovascular events in the overall population and the monotherapy population. Favor vutrisiran with a hazard ratio of about 0.7, 0.6, and a significant p-value. This is for the, again, primary endpoint, and I repeat, all-cause mortality and recurrent cardiovascular events. And then all the secondary endpoints that I mentioned before, the 6-minute walking, the Kansas City score, all-cause mortality, New York Heart Association class, they were all in favor of vutrisiran. Now, going into some details, all-cause mortality and recurrent cardiovascular events, 28% reduction. Then we have second, in terms of all-cause mortality alone, 36% reduction in favor of vutrisiran. The next one, we have greater benefit seen in patients with earlier disease, in patients less than 75 years of age. 45 and 65% reduction, respectively, in all-cause mortality in the earlier stages. And then added benefit on top of tafamidis. So now comparing the drug alone, vutrisiran with the combination was a little bit better with the combination. Was a decrease in mortality 5%, and the overall results were decreased 5-6%. Well, and then we have here disease progression, also in favor of the drug. And then we have NT-proBNP. predicting mortality. And finally, we have adverse events. The majority of adverse events were mild or moderate. So here are the conclusions. Vutrisiran achieved a statistical significance on the primary and all secondary endpoints, reduced all-cause mortality and recurrent cardiovascular events in a contemporary population of ATTR cardiomyopathy. The results were consistent across all pre-specified subgroups, including patients on vutrisiran monotherapy and those on background tafamidis. Acceptable safety and tolerability profiles as previously established, and if approved, vutrisiran has the potential to become the standard of care for newly diagnosed patients and those progressing on stabilizing therapies. This is according to the authors of the study. Exciting. James, what do you have to say?
No, I agree, it's exciting. Patients with amyloidosis have gone from having no therapies a few years ago to now having several emerging possible choices. And so to summarize very briefly, the four major takeaways here are, number one, they hit every endpoint that they examined. So from a clinical trial perspective, it could not have been better. Second, and I think really importantly, silencers previously required an intravenous infusion. Here now we have a subcutaneous administration every 3 months, making it easier for patients. It was beneficial despite a background of tafamidis. That is interesting and important given the fact that we have emerging choices now coming, including, besides other stabilizers, CRISPR for gene editing, as well as depleters to remove amyloid from the tissue. So understanding how these therapies work together will be important. And then lastly, and I think this is something I'm glad you pointed out, the benefits are more noticeable early in disease, which really means that those of us that see these patients for valvular heart disease or arrhythmia really need to think about whether or not amyloid is present in order to get treatment on board at an earlier stage of disease.
Thank you. Anna, are you excited?
Yes, I think I'm excited. I mean, in valvular heart disease, you find, especially in the elderly, you find patients with this disease, and now you have the opportunity to treat them. And I think that helps more the evolution of valvular heart disease patients. I mean,
thank you.
Definitely.
Christine, I suspect you are excited too, but this is much better than tafamidis. I don't know. Do you?
Well, there isn't a head-to-head comparison, but you do see the benefit over it. Yeah. So you imagine that at least it's additive, and you know, we use multiple medications for multiple disease processes, so having two would be great.
Thank you.
Yeah.
Guy, you participated in this study.
No, I didn't participate, but I've been evaluating in the ethical committee, and we were a bit concerned about the gene manipulation, and if we are going to start it in younger patients, will there be any adverse events? But we never know. But it's exciting. It's a new type of doing medication, so I think it's good.
Okay, final question, James. We discussed tafamidis, I don't know, but certainly subcutaneous every 3 months is very appealing, frankly. But the other questions, do you think that when the drugs are available, they can be used both at the same time?
Yeah, that literally is the million-dollar question, and it's likely that there will be controversy about coverage because these drugs are going to be expensive, and so understanding whether we will be able to use 2 drugs at once may be in part determined by the cost of the therapies.
Well, thank you very much. It seems to me we are all in agreement. This is a good move and a very important study.
It's a winner, yeah.
Exactly. 2 studies on atrial fibrillation. We all have been talking about factor 11 neutralization. Here we have a very interesting study, the OCEANIC-AF study, also published in the New England Journal of Medicine. Asundexian, the factor 11 inhibitor, versus apixaban in patients with atrial fibrillation. And this was presented by Dr. Patel, and the first author of the paper is Dr. Piscini from Duke. And I think it's very interesting. we all know about direct oral anticoagulants, a little bit better than warfarin in many aspects in patients with atrial fibrillation, but still we have a question of bleeding. So this is where this paper is quite pertinent. Factor 11 inhibition, well, I think it's like a miracle. We are told that it blocks thrombosis, the intrinsic factors, but the extrinsic factors that protect us, that is the clotting system, that when there is damage of the artery, you cover that. It doesn't prevent that. So very good for no bleeding and maybe a good antithrombotic. This is basically where all this started. Well, let's go into details. There was an original study, a phase 2 study, PACIFIC-AF study, and basically was a study looking at what is the right dose that will make this drug perhaps good competitor with the direct oral anticoagulants. And a dose was chosen. Then here's the hypothesis. Asundexian at 50 milligrams daily will be at least not inferior to apixaban for the prevention of a stroke or systemic embolism. Then another hypothesis, also powered to determine if asundexian is superior to apixaban for the reduction of mesh bleeding. Well, this is the study. It's a large study worldwide, 18,000 patients, follow-up 2 years. And we have here the two agents, asundexian 50 milligrams daily, and apixaban 5 milligrams or 2.5 milligrams twice daily. Monthly monitoring of adherence, etc. Primary efficacy endpoint, stroke or systemic emboli, as we mentioned. And the primary safety endpoint, mesh bleeding. Primary net clinical benefit endpoint, all together. Well, let's see perhaps more details. These patients with atrial fibrillation, of course, with indication for indefinite treatment with an anticoagulant. Interesting, the CHA2DS2-VASc score was rather high, equal or more than 3 in male, or equal or more than 4 in female. Average age, 73 years, 35% women, and few patients, 18%, have actually kidney disease. In kidney disease, we tend to use apixaban at a lower dose when we use a direct oral anticoagulant. Everything went into the wrong direction, interestingly. Let's go to the ischemic events. Well, 1.3% in the asundexian group versus 0.4% in the apixaban group. Unexpected. Well, unexpected. Not known, let's put it in this way. What perhaps was unexpected was the bleeding rates, which is slightly different, but not much different. 0.2% versus 0.7%, strokes less than 0.1%, 0.1%. So this business of the bleeding, what happened is the incidence of bleeding was low from the very beginning. So the hypothesis is a little bit of a problem when you talk about bleeding today. Well, let's continue. Conclusions. Interesting conclusions. Apixaban 50 milligrams once daily was inferior for prevention of a stroke and systemic embolism compared with apixaban in patients with atrial fibrillation at high risk for a stroke. You saw the differences, though. The majority of patients had previously been treated with oral anticoagulants. Important this issue is observed rate of a stroke and systemic embolism on apixaban in this high-risk population was lower than previously observed. So the results actually were not an appetizer. And this is why, in fact, the study was closed before the total recruitment of patients. People were concerned with the original hypothesis. So, anyway, let's start with you. What do you think, Christine, about the study something that we have been dreaming,
Yeah.
this factor 11.
Yeah.
Maybe we need a new dose. What do you think?
Well, there's a couple of hypotheses. I mean, obviously, there's no free lunch. You know, you try to reduce bleeding. It seems that every time we try to do that, we increase the risk of stroke. And so that is one of the issues. I think it was a good study, and it was an important result. We had to know this. You know, people have brought up hypotheses that that it could be due to the fact that some of these patients were already on an oral anticoagulant, and so you have the withdrawal of the oral anticoagulant with the factor 11, and maybe it's not as effective as it would be in naive patients, but that would be a hard trial to do. So I think where it leaves us now is that this just is right now not an alternative. I guess you could try different dosages, but it doesn't make me excited. Yeah.
Right?
Well, as a surgeon, I would embrace if there could come a drug competing with apixaban, because if people come in for operations, acute A dissections or whatever, it's really, really a pain with the bleeding, but we need to operate the patient. So antidote or an alternative drug would really be appreciated.
What is your prediction, Anne? This is going to work, factor 11, or we have to do many more trials?
Perhaps they will try different doses to see if there is a chance for this drug.
Okay. What do you make of it, James?
Yeah, well, you know, as Dr. Albert said, you know, we've recreated the frequently seen, you know, trade-off of bleeding and thrombosis, I think. And you know, to the extent that anticoagulants are the #1 cause of adverse drug reactions in the hospital, it's clearly an effort that's needed to be made. The challenge here, obviously, is whether they have the right dose or if they can get to the correct level of antithrombotic efficacy without increasing bleeding. And at this point, we just simply don't know.
Yeah. Any more questions?
Well, we'll just see what the left atrial appendage closure trials show comparatively, because some of that, what you're talking about, could be eliminated if it was as effective as that.
So let's wait.
Let's wait, yeah.
Let's wait. But disappointing.
Disappointing.
Disappointing. There are other 11 inhibitors being examined, so hopefully, you know, maybe they'll hit the sweet spot.
Exactly. Well, let's now move into the second paper on atrial fibrillation. Is the so-called EPIC-CAD, also published in the New England Journal of Medicine today. Edoxaban antithrombotic therapy for atrial fibrillation and stable coronary artery disease. Dr. Nam from South Korea presented the study. This is a study from South Korea. Well, we all know that we have patients with atrial fibrillation and coronary artery disease. What I would say in the PCI story, what we know is dual therapy, anticoagulation for atrial fibrillation, platelet inhibition for the coronary artery disease, so dual therapy. Following PCI, there is some documentation that perhaps using an anticoagulant alone would be sufficient, and there's some data on that. But today we are talking about chronic coronary artery disease, and there are two studies, one using warfarin and the other using rivaroxaban as monotherapy, that in fact the studies were not completed. So I think the study presented today is an interesting one, and that is edoxaban versus edoxaban with antiplatelet agent in patients with atrial fibrillation and chronic coronary artery disease. So we don't have the answer to that, but I think it's an interesting question. The question is maybe this particular edoxaban is also preventing coronary events in terms of coronary disease, aside of working for the atrial fibrillation. Let's go into some details. This is a multi-center, open-label, adjudicator masked randomized trial comparing edoxaban monotherapy with dual antithrombotic therapy, edoxaban plus a single antiplatelet agent, in patients with atrial fibrillation and stable coronary artery disease. This is important, defined as coronary artery disease previously treated with revascularization or managed medically. In fact, I think these were excluded, is not? I don't know, anyway. But let's move into the primary outcome. The primary outcome was a composite of all death from any cause, myocardial infarction, stroke, systemic embolism, unplanned urgent revascularization and mesh bleeding, or clinically relevant non-mesh bleeding at 12 months. So it's a composite of all the aspects. There are 525 patients in the edoxaban monotherapy group and 516 patients to the dual antithrombotic group at 18 sites in South Korea. 71 years was the average age of the patients, 22% were women. And here we have three aspects. First, what about the primary outcome which was all together, as I mentioned to you before. This is 6.8% in the edoxaban group and 16% in the group with dual antithrombotic therapy. Now, the question is, why this great difference? Well, was not in the ischemic aspects. So basically was in the bleeding. Was mesh bleeding in the group of patients treated with dual drugs, 14%, versus those with monotherapy, 4%. So really what we are talking is about bleeding here. So I want to read the conclusions from the paper in the New England Journal. In patients with atrial fibrillation and stable coronary artery disease, edoxaban monotherapy led to a lower risk of composite of death from any cause, myocardial infarction, stroke, systemic embolism, unplanned urgent revascularization, or mesh bleeding, or clinically relevant non-mesh bleeding at 12 months than dual antithrombotic therapy. Well, this is an interesting study from South Korea. Maybe the clotting system there is a little bit different. There's more predisposition for bleeding. But anyway, James, tell me what you think.
Well, I think, studies like this are really important because they provide practical information for clinicians. The combination of oral anticoagulants and aspirin is something that is particularly common in the United States, actually. The removal of aspirin has been something, or lower doses of aspirin have been argued for years, and yet we still use dual therapy commonly. I struggle with trials that mix efficacy and safety endpoints, and so I was grateful that we were able to see that what drove the endpoint here is a reduction in meaningful bleeding. And so it's a useful finding. The question will be, with such a low frequency of ischemic events, whether a longer follow-up would begin to close the gap with recurrent ischemic episodes.
Yeah, that's right. This was 12 months, just a year.
It's not enough, in my opinion.
Anne, any comments?
Well, I would think that this trial, it is one of the many that have been tried in the balance between anticoagulation and double antiplatelet therapy. I mean, it's years and years that we try to fix this problem for bleedings. It is a complex population, has a lot of, medical therapy, chronic coronary disease. So it's really a mixture of situations. But it's quite an important trial, yes.
Christine, this is simplicity. You remember oral anticoagulants work for coronary artery disease.
That's right.
But it was very tedious approach.
Right.
And so here we have an agent, which is an anticoagulant, and I'm not surprised works for both.
Yep.
And it simplifies our lives. What do you think?
No, I agree. And, with patients, a lot of times I am taking off the antiplatelet at this point, regardless. So this is a nice trial to sort of support that practice. If there's any risk for bleeding, often I will be doing that.
Okay, thank you. So what do you think, Ray, about this study?
I think it's promising. I always like studies that show that bleeding can be reduced and it can be safe. I have patients coming with the platelet and I put them on warfarin, and I don't dare to take away the platelets because the cardiologist said, you must not do it. So I think this is promising, but I agree we need to have a longer follow-up.
Yeah. The study was in South Korea. There's an issue, more tendency to bleed, etc. So we need these to other regions. Anyway, it's an interesting study, and now I think this makes us to go into myocardial infarction. Very interesting, the beta blocker story. Well, anyway, the beta YSS or AVIS study, also published in the New England Journal of Medicine. And the question with beta blockers actually is an interesting one. First, which is not addressed in this paper, is should everybody given beta blockers from the beginning if the ejection fraction is normal? This is not addressed here. In fact, all patients with myocardial infarction actually were receiving beta blockers for at least 6 months. And then in one group, the beta blocker was stopped. And then see what happened in a follow-up. So let's go into the details of the study. The historical benefit of treatment with beta blockers after a myocardial infarction is well known, and this is the standard of care today in patients with myocardial infarction. The question is for how long you should give beta blockers. And we already mentioned when the ejection fraction is normal, maybe we need to answer that question. But the question is, if the patient comes with an MI and is on beta blockers, when we should interrupt the beta blocker? And in this case, it's done at 6 months. But again, we need details. So, the beta blocker interruption among patients with a history of myocardial infarction and preserved ejection fraction actually was more than 40%, would be clinically safe and improve patients' quality of life. This was the hypothesis. But this was an academic multicenter open-label randomized non-inferiority trial conducted at 49 sites in France. Number of patients was actually pretty large, 37,000 stabilized patients post-MI. For 6 months, all had been on beta blockers, and in one group, beta blocker was interrupted. So what about the primary endpoints? And this is important. Death, myocardial infarction, stroke, and hospitalization for cardiovascular reasons. I'm saying this because that's the key of the difference in the whole trial, not in terms of death, myocardial infarction, or stroke. Evaluation at the longest follow-up, 1 year minimum, 5 years maximum. The average follow-up was actually 3 years. Patients were actually over age of 18 years, and I already mentioned the left ventricular ejection fraction, so let me continue. The 3% in absolute risk difference, this is the 80% power to test non-inferiority. We'll talk about this in a moment. Baseline characteristics, age 63 years as an average, 82% were male, and then 62% had ST elevation myocardial infarction, but the rest was non-ST elevation. And then the ejection fraction, interestingly, was 60%, the average ejection fraction, but 20% of patients had between 40 and 50%. Most of them was normal ejection fraction, though. Well, the results were interesting. I would have said that non-inferiority, I mean the hypothesis, but here's the story. Primary outcome, interruption, 23.8%, almost 24%. Continuation, 21%. So, interesting. What is interesting when you look at all the components of this primary outcome, the real difference was hospitalization for cardiovascular reason. It had nothing to do with mortality, stroke, or anything else. I think this is important. And now some details. When you look at death, myocardial infarction, and stroke, 6.8%, 7.2%, no much difference. Death, myocardial infarction, stroke, and hospitalization for heart failure, here you see some differences, 7 to 8.4%. Quality of life, the same. Hospitalization, I already mentioned, in favor of the continuation. Well, the question here is blood pressure, interestingly, if you look at. was a difference in blood pressure between both groups. So in the group that was interrupted, the systolic blood pressure increased by an average of 3.7 millimeters of mercury, and the diastolic pressure 3.9. But perhaps, to me, most troublesome is actually the primary endpoint in hypertensive patients was certainly in significant favor for the non-discontinuation of the drug. So we should keep this in mind. So here's the story. In this study, did not demonstrate actually the safety or otherwise of interrupting beta blockers in patients with myocardial infarction and preserved ejection fraction. But there are some problems actually in terms of blood pressure. So the studies in terms of non-inferiority depends what the statistics you use, but perhaps there is an issue here, or two issues. One, the results related to hospitalization for cardiovascular causes. And the other thing is worrisome, patients with hypertension. Well, anyway, what do you think, Christine?
Well,
you have the question.
Yeah.
We always talk about the same questions.
Yeah, there is something about discontinuing beta blockers that's always made me feel a little uncomfortable, even though, the data in the other trials does suggest that it's non-inferior. And I think that this gives you a little concern. I mean, again, hospitalization for cardiovascular events may not be as hard an outcome, but that's also a predictor of outcome later on. So, I think I'm not as sure that that's really as safe from that trial.
Great. If I have a patient with myocardial infarction today and normal ejection fraction, I don't want to discuss if you give beta blockers or not, because this is being tested. Actually, we have a study testing that. But the question is, would you interrupt if the patient is not hypertensive?
It depends on the other comorbidities. For instance, the 24th organ of the body is the aorta. And if there's hypertension, you can develop dissections, aneurysm, and so on. So I really like to give the patients beta blockers because of the aorta. We see a lot of patients with aortic disease, and they benefit from that.
Well, you're talking with great judgment. I only will tell you the following. In my experience, and I would like to ask James' experience, beta blockers have side effects, so it's not so simple. You give a beta blocker and see what happens, and you use them too a lot. So what do you think about the study, Anne?
I think that makes you think that perhaps there is a possibility of tailoring the therapy for patients. I mean, if patient is a hypertensive patient, then you have to care with beta blockers. If the patient has some issues, then you have the chance possibly to interrupt it. I think it changes patient per patient.
Both of you talking with judgment. That's what it is. James, I don't know. Yeah. So what do you think? Tell me, the patient comes with an MI, has normal ejection fraction. I'm not going to tell you if you give or you don't give beta blockers because we don't know.
Yeah.
But what would you do at 6 months?
Right, so this study provides, I think, some useful insights. First of all, with contemporary revascularization techniques, the risk for hard cardiovascular outcomes, at least over a 3-year period, is low, which is reassuring. But as you said, events did happen, and yet beta blockers have side effects. So how do we find our way through this? I tell my patients that if I'm going to discontinue any medication, we need to think about their case in totality, including whether they're hypertensive, have other comorbidities, a history of atrial fibrillation. Heart failure, obviously, is an important thing to consider. In the balance of things, it's all about risk and benefit. So if someone has well-controlled blood pressure, a lack of symptoms, normal ejection fraction, I will discontinue. I do in my clinical practice, but we do it carefully and we monitor to make sure that, for example, this 4 millimeter increase in blood pressure, that's very significant in clinical trials, won't occur because then you're exposing the patient to risk.
Christine, you deal a lot with beta blockers. I have always been concerned about the side effects. when you talk to patients, really, you grasp the importance of this. So I guess I would like what questions you have about this trial, and what is your experience?
Well, I do think that there are side effects for sure, and you do have to ask about them once you start the medication.
You don't ask, you don't know.
You don't get them, yeah. And then all of a sudden you hear about the fatigue and some of the other things. But often they are well tolerated. And again, I think the one area here is what about that lower ejection fraction group? You know, that was a small component of the trial. Do we really have the power to know whether 40 to 50, it's okay, you know? So again, as the person trying to prevent sudden cardiac death, even though there wasn't a signal there, you know that those patients are more at risk than patients who have preserved ejection fractions.
It is interesting, when we developed the polypill, which actually came yesterday as class 1 in the European for patients with chronic coronary artery disease and questionable adherence. When we developed the polypill, it was impossible to have 4 agents together. It was the beta blocker was interfering with the aspirin. You know, when you give the pills together, there's an interference, which is different than giving separately. And we had to not to give beta blockers. It was very difficult from the pharmacological point of view. So, but anyway, I think this is an interesting study, and certainly we'll continue to have questions about beta blockers, but I tend to agree, judgment, I think is all what you're talking about, the way we should address today. This is the first paper on myocardial infarction. But there is a second paper on myocardial infarction. Let me see, it's the FIRE paper. It was published in JACC, actually. The paper, the title is Complete versus Culprit-Only Revascularization in Older Patients with Myocardial Infarction with or without ST segment elevation. Actually, this paper is from the group in Italy, and Marta Cocco, I suspect, is the one who presented the paper. Well, let's go into the issues, and that is complete revascularization is the recommended strategy today in patients admitted to the hospital with ST segment myocardial infarction. But there are two issues. One is non-ST segment elevation myocardial infarction. And the other issue is there is very little data whether you look at the non-culprit lesions functionally and then you revascularize those who functionally dictate ischemia. And this is, the paper is addressing this, and I'm going to discuss the details. Well, this is a multi-center Italian study. The study aimed to assess whether complete revascularization compared with culprit-only revascularization was associated with consistent outcomes in older patients who were more than 75 years with a STEMI or non-STEMI. There was a physiologically guided for complete revascularization, which we will talk a little bit later because I'm a little worried here. Was a wishy-washy. Was WIRA-based, hyperemic response or not hyperemic response, and then angiography-based quantitative flow ratio. So it was not really an FFR done in a very strict manner. I just mentioned this. Well, the primary endpoint is death, myocardial infarction, a stroke, or revascularization at 1 year. And I want to emphasize revascularization because that's where the difference comes from. Well, the primary endpoint occurred in 21% of the STEMI patients randomized to culprit only, like 21%, but 16% in the STEMI patients of the complete group, complete revascularization. Hazard ratio 0.75. And then the non-STEMI patients, 20% or 21% versus 15% in favor of doing both. And then the secondary endpoints, which is to dichotomize all of these, were all borderline. So the question here is what is the conclusion? Physiologically guided complete revascularization, a little bit question mark, compared with culprit-only revascularization, provided consistent benefit across the whole spectrum of patients with myocardial infarction. And this is with a reasonable follow-up, actually, of 1 year. James, what would you say about this? Do you think this adds anything to what we know?
It adds a lot more conversation with our colleagues in the cath lab, certainly. This comes up so frequently when our patients are in the lab and we get the call that they have the culprit lesion has been fixed and yet they have other disease, and what should we do about it? I struggle with results from studies like this in part because the knowledge of presence of coronary disease immediately will lead to a change in subsequent management. And so interpreting endpoints that are driven by revascularization makes it hard to know if this is really a finding that's based in physiology or knowledge of the coronary anatomy itself.
Great. I have a question here, and that is, it depends on the timing. Here, the revascularization was all done at the same time, but you may wait 2 or 3 weeks, perhaps, and having the same results.
Yeah, I think so. And then you can maybe reduce the use of PCI. And also we have to think of medical therapy with the small vessel disease. So I think it's a clever thing to stage it.
Yeah. Anne?
Well, I think that thinking about complete revascularization, it can be even done sort of a couple of days after the main procedure. Especially if these patients are elderly patients. So probably it is different from a younger population. So I think this trial makes me think a little bit. It's not so straightforward to me, at least in my experience.
Thank you. So one question is the timing when you do the other, but I don't know, Christine, I have a number of questions about this paper, but I'd like to know your opinion first.
Well, I think that, the power of the paper too, I mean, the confidence intervals were really wide, and, because they did this substratified, STEMI, non-STEMI, it kind of reduced the power in both the two groups. And I agree with Jim, what he was saying about, once you know that there's an unfixed lesion and somebody has chest pain, you're so much more likely to bring that person to the cath lab, that it is kind of, the bias is there to know whether that's us or the actual physiology.
James, final question is the functional aspects. If you're going to revascularize completely, are you going to look, functionally speaking, which arteries you are going to revascularize in the non-culprit?
There's so many studies with mixed results about the use of physiologic assessment to guide revascularization that I think I'd probably depend on my interventional cardiology colleagues to make that call. To me, the larger question, as is with the case with a lot of the studies that we'll discuss today, is how will I manage that patient medically if I choose not to revascularize? Because the use of optimal medical therapy for ischemic heart disease, and for heart failure for that matter, other studies that we can discuss, remains suboptimal in general practice. And many patients with obstructive coronary disease do perfectly well on medical therapy. So it's a complex discussion, though.
Yeah, I tend to agree with you. Anyway, I think this is an issue that we face every day, and actually I think all of you, what you are taking is a lot of judgment to do that. Anyway, the results, however, I want to emphasize, the data was in favor, but had to do with revascularization afterwards. So, all right, we have, now we are entering into, I guess, valvular heart disease. Yeah, the first paper is the Notion 3 study, which is let me see if this is, the Notion 3 study, which is PCI in patients undergoing transcatheter aortic valve implantation. So these are patients with coronary artery disease and severe aortic stenosis. And the question is, do you do TAVR alone or do you do TAVR with revascularization? So this is a question that is in the literature and so forth. In fact, it's interesting that coronary artery disease is approximately 50% of patients undergoing TAVR. I didn't know it was so high. And 10 to 20% of patients today in the general population are being addressed both at the same time, 10 to 20%. Anyway, there is no clear answer, and this is the paper today that is presented in the New England Journal of Medicine, was presented the other day. This is an international trial in the Nordic Baltic region. The randomized 1-to-1 ratio, patients with severe symptomatic aortic stenosis and at least one coronary artery stenosis with a flow reserve, fractional flow reserve of 0.8 or less, or a diameter of stenosis of at least 90%. So this was properly done, patients with significant coronary artery disease. And there was PCI or to receive conservative treatment. The patients, in terms of the primary endpoints, death from any cause, myocardial infarction, or urgent revascularization, and safety including bleeding events. And the bleeding event is an interesting aspect that has a lot to do with the discussion here. Well, let's go now into the details. It's a total of 455 patients underwent randomization, 227 PCI group and 228 to the conservative treatment group. Median Society of Thoracic Surgeons procedural risk of mortality score was actually 3%. At a median follow-up of 2 years, measured adverse cardiac events was the primary endpoint, occur in 26% in the PCI group and 36% in the conservative treatment group. And now bleeding, you have 28% events in the non-PCI group, in the PCI group, I'm sorry, and 20% in the conservative group. And so the conclusions are interesting because I don't agree with the conclusion. The first part I agree, the second is omitted. Among patients with coronary artery disease who were undergoing TAVR, PCI was associated with a lower risk of a composite death from any cause, myocardial infarction, or urgent revascularization at a median follow-up of 2 years than conservative treatment. But when you look at the bleeding, you begin to be concerned because it's very significant. So I'd like to ask maybe you, Guy, what is your opinion about this study of doing both at the same time? It looks good on paper, but when you look at the bleeding, you begin to have concerns.
I totally agree, and it tries to mimic surgery, doing both. We always do in surgery, we have to revascularize if we replace the valve. But here, I was discussing also with the author, and I think we should kind of personalize it. In patients without angina, you should maybe leave the coronary obstruction alone and then take it later on if it's necessary, if they develop angina. And I also think in patients with aortic stenosis, you cannot trust the FFR.
Okay, thank you. Christine?
No, I think that I agree with you about the bleeding, and I think personalization is really important in this, using judgment. I don't know that we can just all of a sudden start revascularizing everybody.
I think that we need to understand more, because at the beginning of TAVI era, we we copied the surgeons. Surgeons do bypass and AVR, and we did the same thing, but probably it's not so straightforward. We should need to sort of think about it before.
We already have 4 papers being discussed, perhaps 5, in which the word from you is judgment.
And medical therapy, right?
Yeah.
And that.
In medical therapy.
And medical therapy, I completely agree. This is, and equipoise as well, because we're learning over the years how to manage patients with TAVR, and we are revascularizing fewer and fewer patients now because we see that with good medical therapy after valve replacement, they often don't have angina.
Yeah. Well, anyway, let's continue. Is a number of papers being presented which are fine, but still judgment is the right word, isn't it? Yeah. Well, let's see now. Continuation with valvular heart disease, the RESHAPE-HF2 study. This is a study entitled Transcatheter Valve Repair in Heart Failure with Moderate to Severe Mitral Regurgitation. I would say more in the moderate side. Dr. Anker presented this paper, is from Berlin, Germany. And I'd like to start talking about COAPT, which is the trial we have. In COAPT, patients with secondary mitral regurgitation was a lower rate of hospitalization for heart failure, but also a lower rate of death from any cause. I think this is important. Well, I don't want to touch into the mitral French study, but just to say that this study was actually moderate, in my view, in terms of ejection fraction in mitral regurgitation. For example, the mitral regurgitation in terms of the volume was rather low, and in terms of the orifice, effective orifice, I think was 0.2. So it was rather moderate mitral regurgitation. But let's go into some details. This is a randomized controlled trial involving patients with heart failure and moderate to severe functional mitral regurgitation from 30 sites in 9 countries. The patients were assigned 1-to-1 to either transcatheter mitral valve repair and guideline recommended medical therapy versus medical therapy alone. The 3 primary endpoints were the rate of the composite of first or recurrent hospitalization for heart failure or cardiovascular death during 24 months. The second endpoint, the rate of the first or recurrent hospitalization for heart failure, and the third is change in the Kansas City scoring for heart failure. Number of patients, 505, underwent randomization. Not many patients. 250 were assigned to the device group and 255 in the control group. At 24 months, 37 events per 100 patients in the device group, 58% in the so-called control group, with a p-value of 0.002. The rate of first or recurrent hospitalization for heart failure was 26% events per 100 patients years in the device group, where 46% in the control group. And then the Kansas City score increased by 21 points in the device group and 8 points in the control group. The device-specific safety events occur only in 1.6% of the patients. Now, the conclusions of the study are similar to the conclusions that we had in the COAPT study, except all-cause mortality was not dropped. So among patients with heart failure with moderate to severe functional mitral regurgitation who received medical therapy, the addition of transcatheter mitral valve repair led to a lower rate of first or recurrent hospitalization for heart failure or cardiovascular death, and a lower rate of first or recurrent hospitalization for heart failure at 24 months and better health status at 12 months than medical therapy alone. So at least what I can get from the study, it is very similar to the COAPT study. The number of patients is smaller, and perhaps the patients have less significant disease, and this is why all-cause mortality didn't drop. James, what do you think? Did you learn something here?
So I would say that this study troubles me in a few ways. One is that it took 10 years to enroll a relatively small number.
True.
Second, the evolution of medical management for patients with heart failure was dramatic during that period. And their conclusion that compared to medical therapy, clipping the mitral valve was advantageous in this unblinded study neglects to point out that only 8% were receiving SGLT2 inhibitors, 16% were receiving sacubitril valsartan, and not over 90% receiving comprehensive medical therapy for heart failure. So the concern I have is they compared medical therapy in 2010 to MitraClip. And so what we know is that comprehensive medical therapy, particularly with sacubitril/valsartan, excellent application of SGLT2 inhibitors, beta blockers, and MRAs, results in substantial reverse remodeling. We've shown a 50% reduction in the need for clipping of the mitral valve if a person receives that medical therapy. So I would disagree with the conclusions of this study that they compared to adequate medical therapy, actually.
The number of patients was very small.
That's the other problem. There's a risk.
One of the critical problems.
Yeah, and particularly in an unblinded study, the potential for bias is pretty substantial.
Any comment, Christine?
No, I agree. Those are all very good comments.
Gray?
I totally agree. Yes.
I totally agree too.
Oh, God.
I have to
We're all
say.
All in agreement. Not convincing.
Not convincing.
Not convincing.
Well, I don't know if the next is convincing too.
Yeah.
The Matterhorn trial, transcatheter versus surgical mitral valve repair in patients with heart failure and secondary mitral regurgitation. Let me summarize. Very basically, the paper is trying to say that mitral valve repair is better in terms of few endpoints. However, the degree of mitral regurgitation is significantly different, obviously, after the TER versus the patients treated with surgery. And the follow-up is very short. So in my view, I'm just presenting, I don't think you can, and the patients had moderate disease too. I don't think we can say much about TER being better when in fact you're left with a degree of mitral regurgitation there, which at 1 year may not be problematic, but long term can be problematic. What do you think, Ray?
Yeah, I say the same, because here, and the surgical group, I think it was like 72% that was repaired, and you have to let it go a longer time before you can say the difference between TEER and surgery. And especially, they say TEER is successful if you have 2+ regurgitation, and we would never leave a patient with 2+ regurgitation in surgery. So I think that if you wait for the results, if longer time, it will be better.
Anne?
Well, I think that we have to remember that we are talking about functional mitral regurgitation, and putting a patient under surgery in functional mitral regurgitation, it is not the same thing with the primary MR. So I would be a little bit more cautious. I think that it's been difficult to enroll these patients exactly for this reason, because TR with these patients is more straightforward, safer in some way. They had a lot of complications with surgery. And so sometimes some patients, even if they have 2+ left of regurgitation, they are functional. You have to treat the ventricle, and so probably they are better.
So James, you agree with judgment again?
Again, this is a great discussion from our interventional and cardiac surgery colleagues. I mean, it really does require judgment, discussion about safety and efficacy.
Thank you. Let's go into this final paper, which gave me a lot of headache, but maybe not to you. This is the SELECT trial, the effect of semaglutide on mortality and COVID-19 related deaths. I have to go back to the SELECT paper published in the New England Journal in 2023, which was semaglutide, 2.5 milligrams, reduced the primary endpoint of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And these patients had pre-existing cardiovascular disease, overweight, and they didn't have diabetes. And in addition, there was a 19% lower rate of all-cause death. Again, this is the use of semaglutide versus placebo. Well, we come into COVID-19, and I don't want to go too much into the details, but let's go into what has been news, and that is the overall mortality. And I'd like to give you the figures. First of all, in this study were 17,000 patients, 13,000 had no COVID, and 4,000 had COVID. And the question is the final results. There's a lot of data being presented. And I read this paper 4 or 5 times, but the bottom line is that the overall mortality is 3.7% versus 4.9%. I say I am concerned because I don't know the patients who had COVID, how the randomization worked, because it was not part of the randomization. Mm-hmm. And you are really, it's 1 point difference, 1% difference altogether. On top of it, we can go, the COVID people says we have an answer, now we prolong life, but these patients were overweight, and these patients, had significant coronary artery disease. I presented to you my concerns. James, you have any concerns here?
Is there nothing that GLP-1 receptor agonists can't do, right? It's a post-randomization variable, so it's non-randomized, right? And although a large number of patients had COVID, the question that I would have is, how does one explain a 25% relative risk reduction on the basis of use of GLP-1 receptor agonists? And it may have to do with unmeasured variables. When people are on GLP-1 receptor agonists, they behave differently, they drink less alcohol, they are maybe more motivated to be active and exercise. I simply don't know, however, how we can explain the result.
Yeah, Christine, I have a question about his comment. He said 25% relative reduction, when in fact it's 1% absolute reduction. Mm-hmm. So I am just making this comment because he's right, but I am always concerned about relative reductions, don't you?
Yeah, it's hard when you explain it to a patient too, saying that you have a relative reduction versus absolute risk. But also, I mean, we know that obesity, people who are obese are more likely to have death from COVID. So it's not entirely surprising that this would happen. But would you want to put that into the entire population to prevent COVID-related
many
deaths?
confounders, as James mentioned. It's very difficult. Yeah. And anyway, what do you think, Ray?
No, and I remember last year when we were discussing the SGA, or we were discussing this, there was also mentioned suicide among the patients treated with the medication, and they don't mention anything about that there, I think.
No, they don't.
No.
Anne?
Well, I'm a little bit worried that this drug does really everything, and perhaps it's too much.
Well, I'm glad you are worried, all of you, because I was worried. I was worried too. Well, this is excellent. Look, there are other studies, the Sequoia with hypertrophic cardiomyopathy and the use of aficamten, Senior Rita study, the Duarte study, the FINER-ATS study with finerenone. But we don't have the time to go that. But I want to ask you, which is of all the studies presented today, which we end up with judgment in most of them. Anyway, which is the study in each of you that you feel most is going to change your practice, or you are really looking at things differently? You, James?
The HELIOS-B study.
Okay. You?
I think that's the most impressive study as well.
Yeah, even me thinks that.
Yes.
So it seems to me that we can judge this meeting now. And I think this was the study of the meeting.
Yeah.
And in all the other studies, I was surprised about the asundexian study versus a APIC-CAD study. Didn't go in the direction that we wanted. But all of this is really judgment. All of the rest is really judgment. Well, look, I really appreciate this discussion. You are very good people. There was no much controversy. This is the only worry that I have. But anyway, it is very nice that you came here, and thank you very, very, very much. And thanks very much to the audience. I hope you enjoyed this discussion, and looking forward to be with you again in the American Heart Association meeting in Chicago. Thank you.